So a warm welcome to our audience members, our panelists, and everyone joining us today. And a very happy Diwali to all of those that are celebrating today as well. Welcome to this webinar titled Distributing and Allocating Scarce COVID-19 Vaccines Within Low and Middle Income Countries, specifically how modeling can help. And we have a great lineup today of panelists and speakers who will be discussing, sharing insights, presenting information on exactly how modeling, especially epidemiological, health economic, and operational modeling, can aid in decision-making or planning vaccine distribution and allocation within countries. So I'll just share my screen now. And so the rundown today will be that we'll be welcoming and introducing everyone. And we have two fantastic presentations, which will be followed by a panel discussion and a Q&A of the audience. And so I'd like to welcome Dr. Javier Guzman today, who is the Director of Global Health at the Center for Global Development. Dr. Javier Guzman was previously the Technical Director of Management Sciences for Health and played different roles within the Colombian government as well, including the Deputy Director of the Health Technology Assessment Agency, the Director of Medicines and Health Technologies at the Ministry of Health, and also the Director General of the Colombian Food and Drug Surveillance Institute. He's interested in global health challenges such as COVID and how it can offer a window of opportunity to improve the efficiency and effectiveness of global institutions and build more sustainable and equitable health systems. I'd also like to welcome Dr. Wanrudi Isaranu-Wachai, Director of the Health Intervention and Technology Assessment Program, which is a semi-autonomous research institute of Thailand's Ministry of Public Health in Bangkok, Thailand. She is also an affiliated scientist at St. Michael's Hospital in Canada, and also an assistant professor at the Institute of Health Policy, Management and Evaluation in the University of Toronto in Canada. She's interested in health economics and health technology assessment in the real world setting, as well as how to advance economic evaluation methods. And of course, she has experience in conducting various economic evaluations using numerous methods with specific interests in big data and health economics as well. I'd also like to invite Dr. Justice Novignon. He is the head of the Health Economics Unit in the Africa Centers for Disease Control. And he's also an associate professor at the School of Public Health in Ghana. And finally, I'd like to invite Dr. Zulma Kukunuba, who is a professor at the Universidad Javeriana, Colombia, and formerly of Imperial College London, the MRC unit for Global Infectious Disease Analysis. And so we all know that there's been a pandemic that's been ongoing for the past 2 years. And with the advent of vaccines, vaccine allocation and distribution has varied heavily across many different countries. High-income countries have managed to reach extremely high coverage rates, where you see United Kingdom, United States reaching above 70%, 65%, whereas some low and middle income countries, or many low and middle income countries, are still lagging behind in terms of reaching an appropriate coverage to minimize death and save their economies. And this is consistent across many regions, including Sub-Saharan Africa, South and Southeast Asia, and also Latin America. But there are problems and solutions as well. There's obviously a pressing need to vaccinate those most at risk of death from COVID-19 to prevent unnecessary deaths and economic crisis, and also to improve health-related quality of life. But the supply of COVID-19 vaccines has been severely hampered, and this has led to inequitable global distribution. Adding to this, there's also potential in-country resource capacity constraint, such as transport issues of vaccines, cold storage issues, potentially human resource constraints as well. And therefore, there's key questions on who gets which of the population gets these vaccines first, and how do you get those vaccines to those that need it? There have been many potential solutions, such as fractionated dosing, stretching dosing, using seroprevalence to inform vaccine allocation, vaccinating rural and urban areas at the same time, concentrating vaccine supply in key areas, and of course, other ideas are welcome. But there's always questions on what's the best way to do this, or what's the most cost-effective or most efficient way of distributing vaccines to where they're needed most. And this is exactly where epidemiological, health economic, or operational research is key. It can help answer many different questions through modeling such as to which risk groups is the vaccine most cost effective? Who do we vaccinate first? Which vaccines should you be investing in? What's the modality of distribution? Or do you target hotspot or low immunity areas? And how do you combat supply or capacity bottlenecks? For example, do you buy more cold storage or not to increase vaccine coverages? And so I'd like to invite our three presenters today. We have Dr. Nim Pathy, who's a professor in mathematical epidemiology at the MRC Center for Global Infectious Disease Analysis at Imperial College London. And his major research is in the interface between health and economic systems, and in particular, focusing on the context of TB and lately COVID as well. And most of Dr. Nim's research has been conducted in the South Asia region with a focus on epidemiology and health. We have Dr. Shripad Devalkar, who's an associate professor of operations management and research in the Indian School of Business. And he's interested in operations and supply chain management in emerging economies. And he has a substantial interest and experience focusing on COVID-19 supply chains in India. And finally, we have Dr. Siddhartha Rupani, who's a senior director of global impact at Cooper Software, which was formerly known as LlamaSoft. He's also an adjunct lecturer at the University of Cape Town. He's a senior lecturer for DHL Consulting. And he also has a PhD from MIT in the United States of America. And for all of you joining us today, do please share your thoughts through Twitter, through the YouTube chat as well, or through comments, and do hashtag CGD Talks, because we're interested in your insights, your questions, and keen to hear more from you guys as well. And so without further ado, I'd like to hand it over to Dr. Shripad to begin our first presentation. Shripad, over to you.
Thank you, Hiral, and thanks everyone for this opportunity to share some of the results from our work on using seroprevalence-based vaccination strategies for COVID in India. If you go on to the next slide, Hiral. So as the title suggests, the key question that we're interested in answering as part of this research is, how should seroprevalence information be used to design vaccination strategies? For instance, should we target higher seroprevalence regions first because they represent areas that are potentially at risk because of higher transmissibility in the next wave? Or should we be targeting lower seroprevalence regions because they indicate a larger proportion of population which does not have immunity and therefore is vulnerable to any future waves of epidemic? And what determines high or low seroprevalence? Should we just not distinguish between these two under different conditions? And should we just follow a uniform vaccination strategy? So this is the key question that we try and address as part of this research. Next. And we do this by using the example of urban and rural regions in the state of Punjab in India to model high and low seroprevalence incidents. And this is based on the seroprevalence estimates at the end of the first wave in 2020 in the state of Punjab. And the way we try and evaluate these different vaccination strategies is by doing a retrospective analysis of what might have the second wave in Punjab looked like if any of these different vaccination strategies had been adopted using the actual supply of vaccines that was available during this time frame. And the key feature of our study is we incorporate two components. One is the supply chain model that helps us estimate the rate at which vaccination can be done under each of these different strategies and potentially different supply chain configurations. And the other component is a transmission dynamics model, which incorporates the vaccination strategies and their impact on cases and deaths. And we evaluate these different strategies, not just based on impact, but we look at the cost effectiveness, which includes the cost of implementing these different strategies, the healthcare costs that are either more or less based on which of these strategies is followed, relative to the impact that each of these different strategies has. Next slide. What I will focus on in the remainder of the 5 minutes that I have is on the supply chain model before I hand it over to Nim for the discussion of the transmission model dynamics. The way we developed the supply chain model was to make a key assumption, which is that all the resources that are available in the routine immunization infrastructure in India is what will be used for the COVID vaccination program as well. And this was based on the operational guidelines that were issued by the government of India. And based on this assumption, we first estimated the total resources that are available as part of the RI infrastructure. And because the routine immunization activities were continued alongside the COVID vaccination campaign, only those resources that were not being used or busy with the routine RI-related activities would be available for conducting COVID vaccination. Then we developed a supply chain model to estimate the utilization of the RI-related activities so that we get an estimate of what the resource availability for COVID vaccination is. And then we developed a supply chain model for COVID vaccine delivery using these available resources. And using the supply chain model, we then estimated the COVID vaccine rates and the course of COVID vaccination delivery for different vaccination strategies and supply chain configurations. The vaccination strategies, as I said, are whether to prioritize urban regions or rural regions or do the vaccination uniformly across all geographies. And in terms of supply chain configurations, the two configurations we consider are, one is to use the RI resources that are deployed in their current manner, and the other is to see if there are benefits to redeploying these resources either from urban to rural or rural to urban areas based on the strategy so as to augment the capacity in those regions. Next slide. So this graph here represents the vaccination coverage of the different population groups under the urban first strategy. The solid lines here describe the vaccination coverage under the baseline resource deployment, with black representing the coverage for urban populations and the red solid line representing the coverage for the rural populations. And as the graph indicates, under the baseline scenario, the vaccination capacity in urban regions is a bottleneck, or it's the binding constraint, and therefore there isn't enough capacity to absorb all the available supply, because of which the excess supply can also be used to vaccinate some of the urban rural populations in parallel. And by redeploying resources from rural regions to urban regions, the vaccination rates in urban areas can be speeded up, and all the supply that's available can be used to vaccinate urban regions first before moving on to vaccinating the rural populations. And in either of these strategies, the total population across urban and rural areas gets covered in about 300 days. Next, please. In contrast, under a rural first strategy, because we're prioritizing rural regions first, we start with vaccinating the rural regions. And what we find is there is enough capacity under the baseline scenario to be able to absorb all the available supply when targeting rural regions first. And therefore, redeploying resources from urban regions to rural regions does not help speed up vaccination. However, redeployment is useful in the latter half when vaccinating the urban populations, and it helps speed up the vaccination and reduces the time to cover the urban population from about 200 days to a little over 100 days. Next one, please. And finally, under the uniform scenario, because in total supply is constrained when vaccinating both urban and rural regions uniformly in proportion to the population, there is enough capacity even under the baseline scenario. We're using the resources as they are currently deployed to be able to use up all the supply, and therefore redeployment of resources does not really help speed up things in this particular case. Next one, please. So given that redeployment has certain benefits under specific strategies, we then also wanted to estimate what would be the cost of vaccine delivery under each of these different strategies and for these different configurations. And the cost that we included as part of vaccine delivery was the cost of storage and maintenance of these vaccines, the transportation of vaccines across different stages in the supply chain, and the cost of human resources involved in the vaccination program, essentially the vaccinators who need to be available so as to administer these vaccines. And what we find is the cost of redeploying resources is not significant in comparison to how much they help speed up vaccination. And the total cost per dose varies anywhere between 30 rupees to 32 rupees. And the total cost for the program in Punjab varies anywhere between about 93 crores to about 95 crores. So that's in terms of the supply chain side. I'll hand it over to Nim now to talk about the transmission dynamics model and how these estimates are used to assess the impact.
Great. Thank you very much, Ms. Sripad, and thanks to the organizers for the opportunity to present this work today. So just 5 minutes on the transmission modeling that we did. And I just wanted to start with a brief reminder of the question that's motivating all of this, which is we're really interested in whether COVID-19 vaccination strategies should be guided by seroprevalence. And as Sripad mentioned, we're taking a retrospective. So imagine ourselves at the end of the first wave of COVID-19 in Punjab state in India. And we're asking what type of prioritization would have best mitigated the adverse impact of the second wave. Next, please, Hiro. So here is one example. We're looking at urban and rural areas because these were areas that were known to have different levels of seroprevalence. And as you see in the speech bubbles here, I mean, this also echoes some of the ongoing discussion at the time, which was, when you have areas with different levels of seroprevalence, what does that mean for prioritization? And so we're aiming to address this now using a transmission dynamic model. Next, please. So the model itself is what we call a deterministic compartmental model of COVID-19. And it takes account of the urban versus rural differences in transmission in Punjab state. And as Sripad mentioned, this is integrated with supply chain modeling. I mean, quite often as transmission modelers, it's quite possible to become over-optimistic about the rate at which vaccination can be deployed in different settings. And so we're integrating all of the information that Sripad just showed to try and arrive at more realistic scenarios for the rates at which vaccination can be developed in urban and rural settings. Next, please. And so you'll remember this figure. This shows the rate of vaccination in urban and rural areas, urban in black and rural in red, if you had an urban prioritization strategy. And in the next two advances, you'll remember the rural first strategy, and then next, the uniform strategy. And so really what we're interested in here is bringing all of this into a transmission model and asking what would have been the impact on the second wave under each of these different alternative deployment scenarios. Next slide, please. So just going straight to the results, in terms of the actual second wave that occurred, what you're seeing here are basically model projections for the symptomatic incidence, so daily symptomatic incidence of COVID-19 in Punjab state. And the blue curve, that's the one at the top there, is what might have happened in the complete absence of vaccination. And the colored curves below that in yellow, green, and red are under these different prioritization scenarios for rural first, urban first, and a uniform strategy. And one of the things you see immediately from this is that apparently vaccination wouldn't have that much effect at all, because all of these curves are basically sitting on top of each other. But to understand that, it's useful to think about when the vaccination program actually began. Next, please. And so this is shown by the dashed line here. And you can see that in reality, the actual vaccination program was initiated only fairly late in the epidemic. And this was obviously partly, well, a lot to do with the amount of available vaccine supply at the time. So in order to answer our original research question, I mean, the thing that we can do with a model like this is to perform different experiments. And we can ask, if we wanted to find conditions in which the vaccination program could have its maximum possible effect, could we simulate an alternative scenario where the second wave occurred not in early 2021, but perhaps 2, 3, 4 months later? And this is to really try and get at the difference between these different vaccination scenarios. Next, please. And so this is what I'm showing here. This is an alternative scenario. Remember, the timing of the second wave at the time was completely unpredictable. I mean, we couldn't really have predicted the timing of and severity of the emergence of the Delta variant, which is really what drove the second wave in India. But here's an alternative scenario where that second wave occurred 3 to 4 months later than it did, allowing the vaccination program to have a greater effect. And what you can see here is that there's more separation between these different prioritization schedules. But interestingly, it's really the uniform strategy that actually has the greatest impact, as you can see in the table. So in terms of the cases averted, this appears to have been the most impactful strategy out of all of them. Next, please. So in the interest of time, I'm not showing all the different sensitivity analyses that we did in terms of type of vaccine effect, our assumptions about the second wave and so on. But the overall finding that's consistent across all of these is that the uniform strategy is either outperforming all of the others, it is more impactful than the others, or it's comparable to a rural first strategy. And if we put ourselves in the position of a decision maker at the end of the first wave, remember again, what's going to happen with a second wave of COVID is entirely unpredictable. The timing is also entirely unpredictable. And so in the face of that uncertainty, the most practicable option, it seems here, is really to pursue a uniform strategy where you're pursuing vaccination in both urban and rural settings at the same time, rather than prioritizing one over the other. Next, please. So very briefly, we also incorporated costs. So here on the left-hand side, you see the incremental costs that were associated with the second wave. The blue bar is the cost of vaccination, and this was a cost just shown by Sripad, but also we incorporated the cost of healthcare as well, and this is of hospitalization, of medically attended illness, but that does not require hospitalization, and so on. And interestingly, all of the bars that you see there, I mean, they are all averted costs. These are costs that, that have been saved because of the reduced burden of COVID. If you add up all of these averted costs across all of these age groups, then the averted costs are actually greater than the cost of vaccination. And what that means is that this vaccination program could have actually been cost saving, despite the cost that we needed to put into the vaccination effort itself. And this is mainly because of the averted healthcare costs that occurred as a result of vaccination. So the interest of time, I'm going to move on to the final slide. Sorry, this is just to show that this breakup of different costs is cost saving even under the other alternative prioritization schedules, rural first or urban first. Next, please. So just to summarize, the state of Punjab offers at least one example where the discussions that we were seeing before about we should prioritize urban first or we should prioritize rural first isn't as clear-cut as it appeared at the time. And really, at least in Punjab, it seems a uniform strategy would really have made the most sense. And of course, I have to caution that this is not necessarily generalizable to all other states in India. It's a vast country. But this kind of modeling approach can be a helpful analytical tool for any given setting when we know about the relative amounts of seroprevalence in different areas of a state, what might be the optimal way forward. And the vaccine impact, of course, depends pretty sensitively on timing and how early with respect to the epidemic you're able to ramp up vaccination impact. But even late vaccination could be cost saving overall. And this was the last figure that I showed because of the averted cost of healthcare. And that's it from the transmission modeling. So I'll conclude and look forward to discussion. Thank you.
Thanks, Nim. Over to you, Siddharth.
Thank you, Hira. I will present on the work we did in the early part of 2021, Q1 2021, about how we think about delivery of COVID-19 vaccines, particularly the question of concentration versus dispersion in the delivery. And I'll explain what we mean by those two terms. The work was funded by the Gates Foundation and done in collaboration with a large group of partners whom you see listed below on the slide. Next. What I'm going to be able to give you in my 10 minutes is a very tiny snippet or a taster of what we did. The full paper is available at the link or the QR code on this slide. Next. So what were the key questions? When we say concentrated or dispersed, we're basically talking about, should we be thinking about delivering COVID-19 vaccines through fewer large centralized delivery or vaccination locations, or many small vaccination locations that are very close to target populations? spread out across the entire country. And how does that answer to the right level of concentration versus dispersion differ when we think about different geographic areas of the country? So urban versus rural, or large, sparse geographies versus tight, dense geographies. So that's geography is one very important aspect we want to look at. And then the other very important aspect is how does it vary depending on different levels of available vaccine supply. So as we'll see when we go ahead, one key thing in this is we didn't look at the rate of vaccine delivery or the throughput as an output, but rather we looked at it as a supply constrained situation. And then we said, thinking of available vaccines as 4 different levels, let's look at what the right answer on concentration versus dispersion is for each of those different levels and associated rates of vaccination. Next slide. The goal of our analysis, and therefore what drove our modeling approach, right? The goal wasn't to come up with specific guidance for any specific country, but rather this was a model to see if we could come up with any strategic insights or a framework for thinking about how we think about concentration versus dispersion. That's why the presentation and the paper was titled, How Should We Think About Concentration versus Dispersion? What are the trade-offs? What are the factors that drive it? And to do that kind of strategic insight modeling, we could take different paths, right? We could have chosen a fictional any country and populated a fictional geography with some kind of representative population distribution and health facility distribution. But that's not what we chose to do. What we chose to do was pull up public data for the COVAX AMC countries, the 77 countries at the time that were part of the COVAX AMC, and then look at their statistics on a number of different dimensions. And then we chose what we thought was a sample representative country, which was at the median of many of those important statistics. And then we did some network optimization modeling for that sample representative country. So the next slide, I'll say more. So what were some of the statistics that we looked at when we're looking across the pool of countries? Right? We're looking at overall population, population density. Right? Some countries are small and very dense, some are much larger and less dense, but also health facility density as separate from population density, where the geographical spread of health facilities matters. And then what's the population to health facility ratio? So what was important about the country we looked at was not just that it was at the median of the overall list of countries we were looking at, but also that within that country, when you look at different regions in the country, there was a lot of within country variation. So you could look at different parts of the distribution in the same country. It had large rural sparse provinces, it had dense urban provinces, things like that. Next. So what were we trying to maximize? Right? We're trying to balance, in terms of our delivery output, recommended delivery strategy, the coverage and the cost. So when we think of coverage, we're thinking of vaccinating as many individuals as possible. So we gave the model a reward for vaccinating individuals, and we weighted that reward by a vulnerability index. So you can see the source we used for the vulnerability index on the slide here that came from the Circle Foundation, and it was a multi-component vulnerability index. But the more vulnerable people were weighted higher, so you would have a higher reward for reaching them. Then we had a supply chain set of costs for delivery, which included many of the same components that the first presentation included. And then the model was trying to maximize the reward for vaccinating the most vulnerable people minus the cost. And as I've said, we weren't trying to use throughput as an output, something to be maximized, but rather we were looking at different levels of available vaccine throughput. Next slide. So what did we vary? Right? I mentioned we varied the vaccination throughput, and then we did an extensive set of sensitivity analysis that we won't have time to report today on a variety of the input assumptions. Today, I'd really like to focus on this available supply or vaccine throughput level assumption, and then how it turned out in reality. And then I'll close with saying, even given all the changes since we first did this work in Q1 2021, are there any insights that still hold today? Next. So if you look at the blue dotted lines on the slide, the bottom 4 blue dotted lines are the 4 different throughput levels that we tested. And if you think of individual doses, right, you can think of double the numbers here. So one throughput level would have been only enough vaccine supply available to vaccinate 2% of the population per month with one single dose. That's that bottom blue dotted line. And then 6% is the second blue dotted line, 10% is the third blue dotted line. So it is double the numbers you're seeing on the slide. And then what we have in the bars is how different countries were already doing at the time. So we already could see early in 2021, there were some countries that were going quite slow, that were supply constrained, and some that already had ramped up their vaccination programs to be moving very fast. Next.
So there are 3 minutes left, yeah?
Thank you. So how did things turn out in reality? So first, if we look at Sub-Saharan Africa primarily, which was really, we were trying to look at all the COVAX countries, but the focus of the analysis was, could we make insights for Sub-Saharan Africa? What happened was that vaccination rates overall were very low. So when we look at these numbers, we'll see them overlaid on the graph I showed earlier, but they're all low. They all tend to be largely below the bottom blue line that I showed. And then secondly, the supply came in very sporadically. So it came in spurts. So you see these big spikes and then drops, big spikes and then drops. Next slide. If you aggregate up the entire continent, that behavior also becomes visible, where you see, okay, overall, there are lots of very big spikes and drops, and the overall level is low. So conceptually, right, this is not an actual overlay, but this is just a conceptual overlay. If I look at this level and I put it back on the very first slide I showed you, next, it'll look something like that red line at the bottom. Right? Overall low levels compared to the different throughput levels we tested. And we came up with those throughput levels based on the COVAX supply forecasts at the start of the year. As we know, supply didn't turn out in the way that it was originally planned. It was much lower than planned. So it ended up, what available supply ended up being much in the lower scenarios that we tested, and also much more volatile than we had accounted for originally. But now it's projected that supply will increase to be able to go up towards the higher vaccination rate scenarios soon. So we've just looked at one important dimension about vaccine availability and therefore what rate of vaccination is enabled by that vaccine availability. And we've seen that reality turned out a lot different from our input assumptions. Even given that, are there any insights from our overall work in terms of the output that would still hold today? Close. Next slide, sorry. And I'll just close with a summary, and you can think of this as the very top level summary of our results. For more detail, you can go back to the paper. Right, so things that I think still hold today, even as we look ahead to increased vaccine supply scenarios coming up for Sub-Saharan Africa. We don't need the number of vaccination locations delivering COVID-19 vaccines to equal every health facility in the country. Because for available vaccine supply, you're just not going to utilize the delivery teams if you have so many different vaccination locations. You can use a fraction of delivery sites lower than the number of health facilities in your country. So this seems to apply concentration. But when we think of concentration, we naturally think mentally of mass vaccination sites. But the reality is, when we look at Sub-Saharan Africa and the feasible available vaccine supply, the modeling indicates that mass vaccination sites, where I'm defining mass vaccination as delivering more than 1,000 doses a day, will play a very small role, even when supply becomes at the higher levels of available projections, those higher blue dotted lines. Mass vaccination sites will play a very niche role, delivering less than 5% of the total doses delivered in the country. In terms of health workforce, right here, the first presentation talked about how do we balance available vaccinator resources. Should we try and plan dedicated full-time teams, or should we be balancing with routine immunization and having part-time teams for COVID? And our analysis indicated that in dense urban areas, dense urban districts, even at low throughput or availability levels, you should plan dedicated vaccinator teams. In rural areas, there's more scope to consider part-time teams. And then finally, balancing targeting vulnerable populations first versus just minimal cost for delivery. Right? Defining vulnerability as was defined in our index, the source for which I provided, targeting vulnerable people first, only very modestly increased delivery cost. So you get a lot of epidemiological benefit because they're defined as vulnerable. You target them first, but you're only getting a modest increase in cost. So considering that modest increase in cost is worth paying, and vulnerable populations should be targeted first. That's everything from me. Thank you.
Thank you so much, Siddharth, for that presentation, and thank you to Shripad and Nim as well. I'll now hand over to Javier for the start of our panel discussion with our panelists. Javier, over to you.
Thank you, Hiral, and thank you to Nim, Shripad, and Siddharth for the presentations. Very fascinating results. I guess the first question I have for our panelists is, whether they have any, immediate reaction or reflection on the results just presented, and if they can just talk about their experience also using modeling to inform vaccination strategies. I know, for instance, Juan Rudy has had experience in Thailand, Justice has had experience in Ghana, and Sulma has had experience in Colombia. So Juan Rudy, why don't you start first? Over to you, please.
Thank you, Javier. And first, I really appreciate the opportunity to be part of the discussion, and to all the presenters. It's really fascinating work, what you presented. I think the reflection is, as a researcher, I'm smiling inside to see that, the modeling approach that we know for a long time is actually being used to answer real world policy relevant questions. And, Javier mentioned about the work we are doing in Thailand, and we were fortunate to be working closely with the Ministry of Public Health in Thailand since before vaccine were even available, to develop model to answer questions that Hiral mentioned, like, who should we vaccinate first, which vaccine, and all those. It's part of the work that we are doing, and we're learning so much, including the work that we were doing with CGD through the COVID-19 models comparison consortium that CGD is play a really crucial part. So if I were to come back perhaps to the two presentations here, to Dr. Nim and Dr. Shripad, like really interesting work. Can I highlight it maybe, and perhaps the presenter could share the thought on that. So on the supply chain model, you highlight that the resources you're looking at was the one that not currently being occupied in routine immunization work. But one of the things we noticed, including in Thailand and many other countries, was a lot of resources were redirect or diverted, at least for a certain period of time, to really help the country get a good handle on this situation. So what would happen to the models if you actually have more resources, like, for certain period? Do you think the finding that you have would still hold? So that would be my question for the first presenter, the first set of presentation. And there's the second, maybe to Dr. Siddharth. Again, really interesting, and thank you. The model was quite complex. I was reading through the paper that you referred to earlier, and I really like the summary slide that you put things together. But my questions, more so from another setting, is if we were to really consider this, because take Thailand, for example, we are still in the process of trying to vaccinate more and more people. And certainly where or how do we set up this in the rural area is the question that we have in mind. So to you, like building on from the model you have, like, do you suggest that this model will still need to be contextualized in order to make it more feasible to other settings? Yes, so those are my points, but really enjoy the presentation. Back to you, Javier. Thank you.
Thank you. Maybe we just take the questions from all the panelists before Shipra, Neem, and Siddharth answer. So Justice, do you want to go second and give me your reflections and questions to the panelists, to the presenters, if you have any?
Yeah, thank you very much. I'm happy to be part of this panel. And we all know that models help us to break down complex situations or complex issues to policymakers. And it's very interesting to see how modeling has helped, particularly in the case of India, to address issues relating to prioritization. And one of the key things I learned from the presentation is that prioritizing, using rural versus urban really doesn't change the situation much, right? But the uniform strategy, and I would like to hear a bit more what that uniform strategy really is. I didn't quite get that. The other thing is that timing really matters. So, looking at the situation, I'm wondering if, and I completely agree that at the time in Punjab, the key policy question really may have been, do we vaccinate rural folks, or do we vaccinate rural first, or do we focus on the urban sector and vaccinate them first? But I would like to know whether other equity concerns were at play. There are many other equity concerns relating to age, and the others. I would like to know whether there are other equity concerns that may have been at play at the time rather than just the rural urban, because in the context of Ghana specifically, and in many countries in Africa, the questions really related to whether you vaccinate essential workers, right? From the beginning, we were told that essential workers were vulnerable. So do we really spend the vaccines we have vaccinating essential workers, in which case some countries had a very broad definition of essential workers to include parliamentarians, for instance, in the case of Ghana. So are there other, beyond rural urban, because in the case of Ghana, for instance, the burden really wasn't in the rural area. So I guess that the question for policymakers was clear. Are there other equity concerns that other countries can look at beyond India, or even within India, other states can look at? But let me thank the presenters very much for the useful presentation. Over.
Thank you, Justice. Sulma, could you please go? Over to you.
Thank you so much, Javier. And again, thank you so much for inviting me to this panel. It was, as I said, a really interesting presentations, very stimulating for this conversation. And just want to say that it proves definitely how modeling can be a really powerful tool to present different and alternative scenarios when we have both limited resources and also a time constraint. I also really value the idea of thinking of this, particularly for low and middle income countries, where initial supply has been really limited, and thinking about geographical concentration and dispersion, both in terms of population, but as well in terms of the distribution of the healthcare facilities. And deciding on whether to allocate the number of doses into a small number of facilities rather than on dispersed facilities over a territory. That I think is crucial, and particularly because balancing that the availability of points of vaccinations for according to the geographical distribution within a city, for example, matters in terms of how long does it take for the person to get into the vaccination place, but at the same time, how to allocate the resources so that large facilities can be also provide probably, and according to this the model that was presented and others that we also, other experiences we also have seen in Latin America, how these large centers maybe, or at least at the beginning, an optimal solution in terms of gaining both speed and coverage, especially when the supply is very limited. One question I would like to ask perhaps to the presenters is in terms of considering modeling for a specific local context, we really need to have very good data and a very good sense of what are the possible decisions that are more important, both for decision makers, but as well in terms of public health, and how difficult it is for you, or has been, to receive input from decision makers and stakeholders locally, and also to have the right information to inform the models and yeah, to have as inputs of the models.
Great, thank you, Juan Rudy, Justice, and Zulma. So first we'll go with Shripad and Neem, and I guess I'll just quickly summarize what we want to hear from you two. First, I guess it's important in terms of the relationship with decision makers in Punjab, in relation to their questions, in relation to the data that was available, in relation to the uptake of the results. Also, we heard about the issues of equity and other considerations, and also, you know, the importance of, you know, what next in terms of, you know, the results and how these results could be used further. So over to you, Shiprat and Neem first.
Sure. Thanks, Juan Rudy, Justice, and Zulma for those questions. I'll try and answer those aspects related to the supply chain modeling aspects of the study, and then I'll let Nim address the questions on the impact and outcomes. So regarding Justice's question about, and Javier's summary in terms of interactions with policymakers, we've had varying degrees of success talking to policymakers across different states and at the national level. We were fortunate enough to be able to engage at length with the key players in the state government of Punjab who were involved in the vaccination strategy. And to that extent, the data on the supply chain side in terms of the resources available and how the vaccination program was actually designed, our model is a reasonably good reflection of how it was carried out. There were other aspects in terms of equity considerations, which this model does not capture. But what we do know based on our conversations with the government personnel is something along these lines of trying to prioritize regions in terms of case incidence was done. So not in terms of urban or rural areas per se, but more in terms of looking at different districts within the state and looking at the emerging case counts as the second wave was spreading, the fatalities that were getting recorded to try and say which of these districts need to be prioritized. So that is how it was actually done in the state, by the state. In some sense, this is an approximation of the actual process that was used. This was a question in terms of seroprevalence based strategies that we've received from other people as well in terms of equity considerations. And to that extent, I think the results that a uniform strategy seems to have an equal impact, if not better under different conditions, is good, because this implies that there is no there's lesser chance of equity inequality, right? So regarding your question on adding more resources, Rudy, we've had other versions of this model where we've tried to estimate if the vaccination needed to be completed within a certain duration, how much more resources needed to be added. And we've done those studies estimating a coverage duration of about 6 months or 8 months from the start of the vaccination program. And those cost estimates are slightly higher, as you would imagine, but not significantly different from what was presented in today's study. Nim can speak more about other studies, other sensitivity analysis in terms of considering other states and other districts with a higher difference in the seroprevalence estimates in different regions and how the epi results might change. Have I addressed everything? Yeah, and Zulma, your question regarding data, that's a very good question. I think we were lucky enough that we were able to talk to people in the government, because of which at least the quality of the data on the supply chain side is fairly good. We were also fortunate enough to get estimates on the seroprevalence at the end of the first wave during our conversations with people involved in the vaccination program, which is what has informed the epidemiological modeling in our study. Over to you, Nim.
Thanks, Sripad. And just to take off from that point that Rudy mentioned, thank you for the question about what might happen if you had more resources. So Sripad mentioned to some extent about the sensitivity analyses that were conducted. In terms of the transmission modeling, you could think of the extreme scenario where you have an indefinite amount of vaccination, indefinite amount of cold chain capacity, and vaccinators as well. And in that hypothetical case, you could complete your vaccination program extremely quickly, right? And so the question of whether to prioritize urban or rural doesn't really arise. And I think the questions, the fact that we're having to address this sort of question right now is because of the fact that we had limited resources. So certainly these restrictions would be lifted the more of these resources we have. And so one of the analyses where, one of the next steps, I think, to address Javier's last question could be potentially to look at the amount of resources that we have today, not just the resources that were available at the end of the first wave, but taking a look at the current situation and seeing how important is prioritization if we look at the situation today. But overall, I think the essential insight that we had from that analysis that it doesn't necessarily pay to have seroprevalence guided strategies, I think would be still fairly consistent if you look at the situation in India today. So just as you asked about clarification on what the uniform strategy was, and sorry, I should have made this a bit clearer at the time, but basically this is to say, let's not worry about seroprevalence at all. Okay, so regardless of whether urban or rural areas have higher or lower seroprevalence, we would advance our vaccination coverage in both areas at the same rate without prioritization. And as Sripad mentioned, this really it speaks perhaps more to the equity considerations, because we did hear some concerns with some of the policymakers that we discussed this with, that politically it would be very difficult to implement a program where you're prioritizing urban or rural settings because of these equity considerations. So it turns out this makes sense not just from a transmission point of view, but also from an equity point of view. But Justice, you also asked about other potential prioritizations, and in India specifically, right at the beginning of the vaccination program, there was a lot of focus on specific risk groups, and so these were the elderly, naturally, but also those who were below 65 but had comorbidities, for example, heart condition, pre-existing heart conditions, any other conditions that were known to predispose people to higher severity of disease. And so this, along with the key workers, I mean, these groups are really prioritized in the early stages, at least, of the vaccination program. As we know, the government of India then threw open the eligibility criteria for anybody, basically for all adults. But in practice, many states continued prioritizing their risk groups, their clinical risk groups for coverage with the existing vaccine supply. And so there was that element of concern as well. This was something outside the scope of our current study. We didn't really address that specifically in the current work. But just coming back to Zoma's question at the end about the stakeholders, I think we discussed a bit about the inputs that we received from the stakeholders, but also we've been very fortunate to be able to continue sharing our findings with stakeholders as well. So we've had the fortune of being able to present this work to high-level committees in India that have been making vaccine recommendations, but also through the connections that Sripad mentioned with local government and state government in India as well. And they continue to provide feedback that helps us to refine and develop this work. Thank you.
Thank you both. Thank you for answering those questions. Now, if we turn to Siddharth, there's the question of applicability, and I know you went with the COVAX AMC countries first, and then with focusing a bit more on the Sub-Saharan Africa average country, if we might say. So can you talk a bit about the application of the results? Were the results applicable, and what's the benefit of going with this flexible but not so specific model? So what about that applicability and the flexibility? Two, if you can address the question Justice asked about equity as well. The difficulty in terms of selecting a few facilities only. And again, if you can also talk about the linkage with policymakers and the quality of the data, that would be very helpful. Over to you.
Thank you, Javier. Absolutely. The question on how broad or general you make the model and then how applicable it is to a particular context, that's a major trade-off. And that's also the question that Juan Rudy was asking about how we contextualize this further. And really the thought process there was COVID was fast moving, and the idea was to try and get some high level insights now. And could we set some bounds, right? Draw some feasible scenarios. So for example, vaccine throughput. If we can set some bounds based on vaccine projections, and then the answer that you don't need as many vaccination locations as all the health facilities in your country holds at both the lower bound and the upper bound, you state that with reasonable confidence. And that, so that was the strategy we took. In terms of convincing decision makers, right, policy makers, and then applying it, it naturally helps a lot more if they see that you've taken their particular geography's data and applied it. So there is a gulf of taking a conceptual model and then convincing them that it applies. And I think then there wasn't done in this project, there wasn't a demand to do it because the vaccine supply didn't justify it. But there was a planned step of stating these as the initial conceptual findings, and then for any countries that wanted follow-up work, could we design a rapid model where we could quickly pull in their data into the structure of the model we had already built for the example country, and then update it for their geography, and then say, here's how it differs for your states or your regions. So that was a planned follow-on, but it hasn't happened simply because the vaccine supply, all the focus was on procuring or obtaining more vaccines, and there wasn't really much thought about concentration versus dispersion of the vaccine. So that's to answer the first question. And the second question about equity considerations. Yeah, so I think the COVID Community Vulnerability Index, the CCVI that I referred to from the Serco Foundation, is a very interesting attempt to try and have a multi-dimensional look at vulnerability and address those equity concerns. So some of the dimensions they had in there were age, poverty, population density that makes it more prone or epidemiologically risky, and a number of other factors. Yeah, transport availability to be able to travel to another vaccination location. So they had a number of these dimensions in there. And so when we talked about the reward for vaccinating an individual and then weighting that by the vulnerability index, we were trying to address equity concerns directly by saying there is this multidimensional vulnerability index, and we're rewarding the more vulnerable people vaccinated first as more, and the model is then balancing that with cost. So that was our attempt to address equity. It's not going to address everything because some people will say my definition of equity is everybody should be within 10 kilometers or 5 kilometers of the vaccination location. So we also ran some further scenarios about distance bands for exactly that. Everyone in the population must be within a certain distance band of a vaccination location. And the broad qualitative conclusions didn't change, but the numbers, of course, did change when we put those distance bands on them. So those were our two attempts to address equity.
Thank you very much. We clearly see how modeling can be helpful and answering important questions, and how actually the answers might be a bit counterintuitive on one hand, but at the same time, difficult to implement often because policymakers have different opinions or have different set views regardless of the results. So I just want to go back to our panelists and ask them, how can we bridge that disconnect between the modelers and the policymakers? What's the best way to actually align, the two communities in your experience, in the regions where you are? If we can talk a bit about that. Now we start with Sulma first. If you can talk a bit about that, please. Over to you.
Thank you, Javier. Yes, I think this is a really crucial point. I was really happy to see on a recent document from WHO about good practices on modeling for TB, actually, that they said they put a set of 10 main points on how modeling could be much more informative for decision making. And one of the points they mentioned, and I completely agree with that based on my experience, particularly during the pandemic, is that models should be ideally be constructed from the very beginning with stakeholders. With input from stakeholders, it doesn't mean the technical details, but in terms of deciding the as Siddharth mentioned, like the bounds of the potential projections in terms of vaccine supply, or the bounds in terms of policy decision for example, changing social behavior, and also deciding what are the crucial scenarios for them to be able to choose between options. And obviously in terms as well of gathering the right data to answer the right questions. So I think my point being the central point of what I am trying to say is that process should start from the very beginning, ideally, and should continue to over time. And ideally, and now is what I am trying to ask myself as well, is how to keep that collaboration ongoing beyond this point, as perhaps willingness to have that collaboration starts waning over time, and how to keep like the momentum of this relationship that has been stronger than ever during this pandemic.
Thank you so much. Good point about stronger than ever and engaging decision makers early on. Justice, what are your views on this question?
Yeah, thank you, Javier. I'll make 3 quick points. The first one is straightforward. Now, how do we bridge the gap? The relationship between the modeler and the policymaker is key. A policymaker is not going to run to you to run scenarios if you don't have an existing relationship, certainly not in the context of COVID-19. So it's important for us to keep that relationship, with very close relationship where we can work, we are at arm's length from the policymaker. But the other issue is, who really is the policymaker, particularly within the context of COVID-19? Remember that ministries of health are not handling the response alone. The response is also being coordinated from the offices of presidents and prime ministers, and sometimes actually off the hand of ministries of health. So it is important that we actually identify who we are dealing with, because we may actually address one person's concern, and I had that experience, and then you notice that there's actually another person who is also within the context, a policymaker, and you need to address that concern. My final point really is that, models are not static. Well, I know some models use static assumptions, but especially for health and for policy, the target is always moving. So just like in a relay race, you have the 2 runners, who don't actually stop before they pass the baton. The first runner is actually running and wanting to pass the baton, but the target is actually moving, and you need to keep moving. I think that is the relationship, especially in this case, between the model and the policymaker, because policy questions are fast changing, and running models can take time. Parameterizing your models can take time. So if you want, by the time you actually set to address one question, the policymaker may have moved to a different policy relevant question. So it means that modelers will always need to be on our toes and be looking out for what the policymaker really wants. And I think that COVID-19 has given us a very good opportunity to change the way we work, the way we run models to inform and improve our health systems. Over.
Very good points. Thank you, Justice. But Rudy, what is your take on this, especially in Asia and in Thailand, where you've been working on this? Over to you.
Thank you, Javier. And I absolutely agree with points that Soma and Justice brought up. So perhaps I can share another angle to this, which align very much with what they've been saying. But I was looking back, like if people were to ask what you would think about or what come to your mind when you look back to the year 2020 and even now, for me, I think it's the 3 C. The first C is COVID-19, obviously, but the other 2 C, I think that will help with bridging the gap The second C would be collaboration. And the third C would be communication. Because I think to bridge this gap, you need to do both, right? And perhaps I can share more from the research perspective, because as I'm a researcher, for the policymakers, I can share partly that we've been fortunate. As soon as COVID started, at the Ministry of Public Health in Thailand, they formed what they call an intelligence unit. And this intelligence unit within the ministry has direct line to the executive at the ministry and at the country level. But there were also space for researchers to join and to be part of that discussion, to receive direct questions that they're answering. So obviously in the early stage, we got questions and we have 48 hours to answer. There's no models that can help us with that. It was more quick review, reaching out. We reached out to colleagues in CGD to throughout the world, because we know we were asking similar questions. So I think if there are a platform for policy maker and researcher to connect, in that case, it would be really beneficial. Now for the research side though, as Justice highlight at the end, we got to be ready. The question will come, and I think a lot of time we talk any project, we said, oh, what's the research question? But now we need to add, okay, it's an interesting research question, but what's the policy relevant or policy implication to that? So I think as researcher, COVID really highlight that there's still gap, but I think COVID in many ways is a bridge between these two worlds already, as we have seen in the works that the presenter has shown today. And perhaps I can finish by just thank you, CGD, for putting platform like this for everyone, for researchers, for so many group of people to be able to come and learn together, because the question that are being asked is not just one country that faced with that situation. So thank you.
Well, thank you very much. Unfortunately, time is running out. So I think we just heard how modeling can really help, and the different elements of combining modeling. I mean, we heard supply chain, health economics, we heard operational, in terms of informing policymakers about the decisions they have to maximize the limited supplies they have. I was really interested in hearing these takeaway messages about engaging with the policymakers early, identifying who the right policymakers are, nurturing the relationship with them, being, ahead of the game, and, the importance of collaboration and communication. I also think it's important to revisit the point about collaboration, networks, and understanding that the question, some countries face are the same question other countries, other regions face, how we can offer a platform for all to work together. So thank you very much to our panelists. Over to you, Hirad.
Thank you very much, Javier, for chairing the session, and thank you very much to all of our speakers and panelists, and for our audience members who have joined today for this session. And as Javier has mentioned, modeling is a powerful tool when there's limited resources and time constraints, which can help us understand policy relevant scenarios, especially complex ones. It's obviously important, as Justice reflected on, that is a simulation, but it can still be useful when no other information is available. So I urge everyone really to look at the value of generating and using evidence through modeling, and for all of the global health community to collaborate, communicate, cooperate to combat COVID-19. Once again, I thank all speakers, panelists, and our chair, and the audience members for this fantastic session and for providing their insights. And do tune again into the CGD talks via our website for further conversations on global health topics and for other wide-ranging topics as well. Thank you again, and look forward to seeing you again. Thank you.